everyone, and thank you for being here. And I'd like to invite you to the March ADPC meeting and welcome all our commissioners as well as members of the public. And just a quick reminder for members of the public to please stay off your camera and hold your comments until the public comment period. That will be at the end of the meeting, and we do encourage you to use that time. And at this point in time, let's go ahead and start roll call, please.
Thanks, Debbie. I will start with Commissioner Sheriff Massey. Don't know if Caprice is on yet. Caroline Cruz.
Here.
Debbie.
Here.
Eric. Did not see Eric yet. Erica Fuller.
Here.
Fernando. Pena. Fernando's here. Thanks, Fernando. Frankie Hupy. No Frankie yet. Our newest commissioner, Jennifer Kearley.
Hi, everyone here.
Thanks, Jennifer. Julia Mines.
Here.
Julia. Katie is going to be absent today. Commissioner Minty. Okay, yet. Maris Alden.
Here.
Monta. See Monta either. Moxie. Mike. Did people forget to set their clocks today? I wonder. A lot of these people did accept. Sharon Dursey Martin.
I'm here.
Hey, Sharon. Shira Marila Simmons.
Present.
Hey, Shira. Stacy.
Here.
Tim Lynch. Tim might be out. Tony is, I believe, excused. Vanessa. No, Vanessa. And our non-voting members, Senator Reynolds.
I'm here.
Hey, Senator Reynolds. Anybody joining us from Rep Sanchez's office? No. Judge Rick Maiden.
I'm present.
Cute. And Ebony.
I'm here. I have to step away at 1:30 and 2:30 for a couple meetings, but I'm here.
Thanks, Ebony. Okay, that is concluding roll call. I will try to catch people as they come in, Debbie.
And do we have enough for quorum?
6, 7, 8, 10, 11, 12, 13. Yes.
Woo, good job, you guys. All right, just to give you an overview of our agenda today, we will have updates from Director Dolph and a special welcome to our new commissioner as well as new staff. We have a potential name change for one of our committees, so we want to update the group on that. OHA will be presenting on the Rural Health Transformation Funding that's coming to Oregon and how they're aligning with our ADPC comprehensive plan. We'll have a legislative session update, and then we'll close with committee updates as well as public comment. So, Annalise, I will turn it over to you.
Thanks, Debbie. I think we've got Eric joining us as well. So I'll make a note that Eric joined. Hey, Eric. We're just getting started. So I will do quick updates and then turn it over to our new commissioner and our new team member to introduce themselves to you. We do have a couple of reappointments So reminder to my folks who are being reappointed, I'll reach out to you after this if I haven't gotten your application in yet. And we still have one opening to replace Frankie. We are looking for an attorney that can be a public defense attorney, district attorney, or assistant attorney general. So if folks know of somebody who might be interested, feel free to send them the application packet or connect them to me. Those applications are due April 1st. So trying to get folks into those slots. Looking at summer schedules for July and August. So if we have time at the end of the meeting, we might have a little extra time. I might poll you all to see if we want to cancel July this year. And potentially thinking about 2 more in-person meetings. So I'll put that out there in case anybody would like to host a meeting or would like us to come to your area and maybe host a tour of some exciting stuff happening locally while we are in that area. So putting that out there to folks, it would probably be nice for us to hit Central or Eastern Oregon and Southern Oregon at some point this year. Opioid Settlement Board updates. The board met, was it just last week? Yes, just last week to start discussing developing a plan to allocate the remaining $10 million this biennium. We didn't make any decisions. It does sound like folks are leaning towards doing a request for proposals. And then we would allocate across the continuum, kind of approaching it as seeing what we get in and not being as necessarily possibly as hard and fast to say exactly this amount goes to this item as we have in the past. So continuing to discuss that. The Purdue and group of 8 settlements still have not been finalized. So highlighting that for folks who I know are really tracking that locally and are wondering where the rest of that money is. They still continue to work through that. And the annual report of local and state spending is now available online. So I will put that in the chat. Those are my main updates. Next month, when we meet in April, we are going to have our first quarterly implementation update for the comprehensive plan, and we have a lot to share. So I'm going to hold most of my other updates to next month for that. So I think that is everything. Wes is going to do a quick legislative update later in the meeting after we hear from Rural Health Transformation. So that is all my updates. I do want to take a couple of minutes to allow our new commissioner to introduce herself, and then we'll go to our new staff member. So Jennifer, do you want to introduce yourself?
Hi, everyone. I'm Jennifer Kearley. I'm the Juvenile Department Director in Washington County. I've worked in juvenile justice for the last 25 years or so, starting in Lane County, and I moved up here to Hillsborough about 9 years ago. It's really nice to meet everybody. I'm super excited about this work and moving things forward.
Thanks, Jen, and it's great. We appreciate you stepping up and bringing your expertise to the table, and we'll find out. Has Jen decided which committee she's going to join? I don't want to make this like a, hey, you know, all of us have great committees.
I think I'm open, and I know I've heard about the youth committee and the prevention committee.
Great. I'm sure you'll do great wherever you land. And we want to turn it over to Ash.
Hi, everybody. I'm Ashley Olson, she, her pronouns. I live in Eugene, Oregon, and I'm transferring here. This is going into my 3rd week with ADPC. I'm transferring here from the Higher Education Coordinating Commission, where I started my career in the state in 2024. So I'm really new and figuring things out. But I come into this work with a trauma-informed lens. I have a psychology degree from the University of Oregon. Go Ducks. Go Seahawks too. And I'm just really happy to be here and to do this work with you and to learn. I am a sponge. So thank you.
Welcome, Ashley. And I know we've had that chance and some of the subcommittees to meet you. So we're really grateful again to have the team being all together, and the work that you do is very important, as is all of our ADPC staff. So thank you very much. Wes, how about that legislative update?
I think that's going to come a little bit later. We're
okay.
going to try
Kind
to
of
run
said that,
through.
and I'm
Yeah,
just going by the script.
yeah. Stacy we're going to turn over to Stacy. Ashley has some slides. Folks will remember we mentioned before about potentially changing the name of the harm reduction committee. So Stacy's going to walk you through their recommendation. Before we go into this, just to set this up, I will share the bylaws do not have the names of the committees in them. The bylaws just give you all, as the commission, the ability to say, these are our committees and this is the scope of the committees. We thought it would be best and transparent to bring this here to you and perhaps at the end have a consensus vote where everybody kind of votes yay or nay at once. But happy to discuss that if folks have other feelings about it. But just wanted to set that up for the goal for the next 15, 20 minutes while Stacy dives in.
Thanks, Annalise. Okay, Stacy and Doniatis, thanks for having me. The slides are coming up. So I'll just give a brief reasoning refresh as to why we are changing the name. The current name is the Harm Reduction Committee, and we're recommending a shift to the Health and Safety Interventions Committee. I don't see the slides. If they're still coming up, that's okay if it's taking some time, but just to make sure that I'm not seeing them.
I will have them up in just a second.
Great, you take your time. I just want to make sure that I was not missing something. Okay, so again, you'll see the slides in just a second, but the recommendation is to shift to the Health and Safety Interventions Committee. And there's kind of two main reasons. The first reason is there was guidance in the summer of 2025 from SAMHSA and an executive order from the current administration that was requesting SAMHSA stop funding. There we go. Thanks so much. So here's the recommended shift, and we can go to the next slide. So thanks, Ashley. Appreciate it. So the recommendation was to remove or to shift away from harm reduction language, the actual words harm reduction. It was not very clear as to what harm reduction exactly was. They're telling us that there will be more recommendations in the future from SAMHSA clearly articulating what harm reduction was. So that's kind of what that second paragraph, the one on your right, is saying. And the first one was this intention to really connect the idea of harm reduction, and safe consumption with illegal drug use. So this was in July of 2025. And over the next several months, we talked about this at the Harm Reduction Committee. So this is one of the reasons why. And then the second reason is that the committee really oversees more than just harm reduction activities. And so we thought that a different name would be more representative of the work in the work plan that's been approved to do over the next 4 or 5 years. So this is the why. I will go to the next slide. Or yeah, Ashley, if you could go to the next slide. Sorry. Thanks so much. So I wanted to share transparently the process that we went through with the group. Mara had just wonderful conversations individually, which each of our members, we worked together to propose options. In January, we had a group discussion, which actually led to needing to refine the different options that we came up with. And then in February, we voted to change the name to Health and Safety Interventions. So there was a pretty lengthy conversation, communication, discussion around different options, and then a vote at the now hopefully Health and Safety Interventions Committee. We can go to the next slide. I wanted to just share some of the poll results so you could get an idea of the names that we are wrestling with and what the clear winner was. So you can see health and safety. It was really, most people voted, which was excellent. We had lots of participation, robust conversation. And then I think we can go to the next slide because some of those answers were cut off, and I just wanted you to see exactly what people were sharing. Those were the suggested options. We had people really very clear and honest about how they wish that they could keep the harm reduction name, but also understood the importance of shifting away so that we could preserve this really important work and associated funding. Annalise, am I missing anything? Would you like to add?
No, and I'll if Mara would like to hop in at all. I mean, I'll just say thank you to you, Stacy, and to Eric for your work with this committee. I think this committee has had to think the most about their language and protecting the services that we have. And than any other committee has had to over the past year. And so I think this was a really hard conversation for the committee, but I think it was a really well thought out recommendation.
Thank you. Yeah, and Mara, if you're, please feel free to add in anything that I missed. She really just facilitated and shepherded this process forward. So huge kudos to her. So Mara, did you want to add anything?
Y'all got everything perfectly.
Okay, thank you. And thank you for the slides as well. I'm not sure, did you want to vote on it or what? I'll hand it back over to you.
Yeah, so there's one more slide that just puts the language back up. Yeah, so the proposal, and again, like it's not in the bylaws, but I think it would be really meaningful for the committee for folks to do a consensus vote. So the proposal is to rename the Harm Reduction Committee to the Health and Safety Interventions Committee. And so I think we would do it kind of like a normal motion where someone makes a motion in seconds, but then we just say all in favor, aye, all opposed, nay.
Okay, do we have with that presentation? And thank you for the reasoning with all of that. And do we have someone that would like to make a motion on changing the name?
I will make a motion to change it. Yes.
Okay, thank you, Moxie. We have a motion to rename the Harm Reduction Committee to Health and Safety Interventions Committee. Do we have a second?
I will second.
Fernando.
Yes.
Thank you. We have a second. Any further discussion? Okay, I think we are ready to proceed with a vote.
So Ashley, do you want to take down the slides and we can say all in favor? I would say you can either thumbs up or raise your hand.
Seeing lots of thumbs
Yeah.
and and
Yeah. Does anyone, if you want to put your hands on, does anyone oppose? I'll say it again now that everybody's hands are done. Does anyone oppose changing the name to Health and Safety Interventions?
I think we have a unanimous response. And again, thank you for that committee. I'm sure it was challenging, and I know that you guys really went, all of your committee members really went into addressing during a challenging time and the importance of the work that it continues to go forward. So thank you. Annalise, are we gonna go to the rural health?
Yeah, we are running a little ahead of time, but if our partners at OHA are here, we can go ahead and transition over to the rural health transformation update. I am not sure who is presenting from OHA.
Lizzie's here.
Hi, all. I'm here. I'm here with Yudi Liu, who's gonna start us off. Oh, Yudi, you are on. Great. And would you all like us to drive slides, or are you planning? Yeah.
Yeah, are you able to share?
Yes, I can do that right now.
And while Lizzie pulls that up, I think this is my first time in such a space, so I'll make a quick introduction and thank you all for having the RHTP team join this monthly meeting. Hi, everyone. My name is Yudi. I use she, her pronouns. Similar to Lizzie, I'm out of the Office of Health Policy. And for the purposes of this program, I'm serving as Chief of Staff. So really excited to integrate your ideas and expertise into what will be a 5-year program. So quite the ramp. Now, I'm going to wait until the slides are pulled up. Also want to recognize that we've spoken with some folks here one-on-one or in separate meetings, but thought that it would be helpful to start from a shared place of understanding and background. And so the first few slides will be providing that background, and then I'll pass it over to Lizzie, who will kind of dive into the interplay between ADPC and RHTP. Next slide. This is just a disclaimer around the program, how it's supported by the Centers for Medicare and Medicaid Services. Next slide. So the Rural Health Transformation Program, RHTP for short, came out of the HR1 reconciliation bill, also referred to as the One Big Beautiful Bill that was signed into law last July. This was the massive cuts to federal funding on Medicaid, food benefits, and other federal programs. And it has been made explicitly clear that RHTP is not intended to offset HR1 Medicaid cuts. So that's a fine line that we need to design around in our program implementation. In contrast, HR1 did establish RHTP, which makes $50 billion available across 5 years to all 50 states. And the Centers for Medicare and Medicaid Services is the agency administering this program as a cooperative agreement.
Sorry to interrupt you. Folks in the chat are saying there's feedback and static. Is there something on your end?
There's a way to go into your audio settings and setting the background noise suppression to auto or high. Uncheck the automatically adjust microphone volume setting, and that should fix that.
Okay, let me actually grab my headphones. Lizzie, would you be able to capture
Sure. Absolutely.
next few slides?
Absolutely. Are you all still able to see the screen? Okay, wonderful. So again, this is just a little bit of background. Oregon is receiving 197.3 million, so pretty close to the 200 million that we applied for. And the assumption is that if we were to receive a similar amount each year of the 5-year grant, that would be about $1 billion in investment in Oregon's rural communities. This slide just reviews the overall goals of the Rural Health Transformation Program at the federal level. Again, I know some of you have gone to some of the webinars, so I'll just go through this pretty quickly. But Make Rural America Healthy Again is really focused on this idea around rural health innovation and increasing access to care, sustainable access, and this is around the efficiency of our healthcare systems, workforce development, innovative care. This goal includes things like innovative payment mechanisms and value-based care, and tech innovation, so innovative technologies. Innovation is the word as a theme. Yudi, I will hand this
Yeah,
back over to you to talk about Oregon's interpretation of all this.
great. I'm back, and is the audio, are we getting, okay,
That's great. Yeah, thanks.
thanks for flagging that. So, I actually really liked how Lizzie framed this as it is an interpretation of CMS's broader directives. Um, but as you probably extrapolated from that last slide, the strategic goals are really broad. And so, what this program aims to do is tailor that to what we know are the health service needs and health related social needs of the communities, the rural and remote communities across Oregon. And the way that we're framing this up is in this diagram below or table below, in terms of really thinking about access and outcomes. How do we improve that with the funding? Also, in concert, driving technology and data innovation, and then standing up workforce capacity and resilience. So that's from retention, recruitment, to also training. Undergirding those three domains, we see financial stability and sustainability as critical, because, you know, after this 5 years, that will be a funding cliff. And so if the solutions aren't financially sustainable, the work itself is not going to continue, and such access related programs may themselves halt because of unsustainable funding. And then strategic partnerships, thinking about leveraging locally driven and regionally driven networks to help sustain this work past the 5-year program. All right, next slide. And so, did we touch on Oregon's 5 initiatives? I actually, if we can go to the next slide, I think let's start there, and then we can always go back to the framing piece. Oregon proposed 5 initiatives as its RHT program. One of the 5 is a tribal set aside, so that's what you see on the right-hand column. We have designated and set aside 11% of the total funds for the 9 federally recognized tribes to essentially create their own initiative and activities under that initiative. Separately, Oregon has 4 initiatives that are state-led, and those are regional partnerships and system transformation, healthy communities and prevention, workforce capacity and resilience, technology and data modernization. And if you recall the slide around strategic goals, the CMS strategic goals, we intentionally designed these initiatives so that they would have a relatively easy one-to-one match to those strategic goals. Essentially, to demonstrate to CMS, we are positioning our program competitively, and we intend to meet all of your strategic goals. So healthy communities and prevention, think of that as population health, chronic disease management, exploring new ways to deliver care, whether that's through mobile clinics, telehealth, other non-traditional models of care, and also integrating with behavioral health and really achieving maximum care coordination. Workforce capacity and resilience, this is what I said earlier about focusing on the full spectrum of retention, recruitment, and training, touching early pathway programs, K through 12, to graduate medical education. And this is beyond just your MD programs, but also can be nurse practitioners, PAs, community health workers, really having an expansive view of what we define as healthcare providers here. And then technology and data modernization. This is focused on ensuring that rural healthcare systems and rural communities have access to the latest and greatest with technology and data infrastructure, both being efficient in what they use and also driving efficiencies in care coordination with such new tools. And then I did skip over the left hand column, regional partnerships and transformation, systems transformation, intentionally, because I think of this as the momentum that's undergirding the other three initiatives. So this is where we're really relying on providers, health systems, and community-based organizations to partner together, not only to identify what are the local needs of their community, but to come up with solutions that are tailored to those local needs. So you can see a list of examples for uses of funds under that initiative to the left. So if we can go back a slide, I think the framing of the initiatives, the takeaway here for the 5 initiatives are that we designed them in response to 2 public comment periods we had back in the fall and summer. This is where we asked the community for their ideas on ready to go projects that could be launched in the next year. We also asked about their pain points and challenges, and to think about, okay, how do we design and be responsive towards these community identified needs in our initiatives and prioritize them. And we also, as I alluded to before, wanted to align with the CMS strategic goals and finally ensure that the money is invested in a way that is sustainable in the long term. Final 2 slides here. One is just about how Oregon is defining rural communities. We're using the Office of Rural Health's definition as described here. Areas greater than 10 miles away from a population center of 40,000 or more people. And then we are also leveraging the Rural Health Coordinating Council. This is currently a council that advises the Office of Rural Health and will serve as an advisory body also for this program.
Yudi, before you go on, we had a question in the chat. It's one of my favorite questions that we get in Oregon. What is the definition of frontier?
Yeah, I would have to look that up, but it is part of the definition of rural. So if you are remote or frontier, you are also rural. I think it's just the number 40,000 is increased to another digit.
I think it says counties with 6 or fewer people per square mile.
Mm-hmm. All right, Lizzie, off to you.
All right. Any other just general background questions before we move forward? Okay. If they come up, feel free to drop them in the chat or come off mute. We wanted to share a little bit with you all about places where our RHTP application and plan is aligning with the plan that you all have developed. So there's quite a few places across really all of the initiatives where work could be happening to move forward your plan. Behavioral health and substance use, are layers on top of a lot of the regional planning and telehealth conversations. But there are some specific objectives and targets that we built in that really align particularly strongly with the work you all have done. So I wanted to just bring attention to that. So under your health and safety, do y'all call it like, is it a plan or a component of your plan?
We call them like area, the continuum of care areas. of
Okay. Thank
care,
you.
Yeah.
I want to make sure I'm using the right lingo. Okay. So under the health and safety area, um, you all called out encouraging more naloxone distribution in communities with low access. And so we have a specific target for the first couple of years of our program to increase access to naloxone. And we're going to be focusing that work specifically on the 7 counties that have seen an increase of overdoses while the rest of the state has experienced a decrease. The treatment area, in terms of ensuring timely access to the appropriate level of care at all entry points, we have some targets related to supporting EMS pilots in rural communities related to overdose reversal and initiation. We know that there's been some work more in urban areas, and so trying to lift up the learnings. There's also in year 3, starting in year 3, we'll have work that's specifically increasing the availability of remote medication-assisted treatment and ensuring the connection to local emergency departments. And while that was a target that was written into year 3, it's absolutely possible and likely that we're going to be seeing applications in this year's grant program for Medicaid assisted treatment. Yudi talked about the public comment periods. We also did an intent to apply survey where we had as an option folks contribute the types of projects that they were hoping to apply for, and that gave us a really good sense of, what people are hungry for, what people are already working towards, what kinds of conversations are happening with partners. We also have specific targets relating to ambulatory detox programs. So this one says assess feasibility and implement ambulatory detox programs. The feasibility aspect will be starting this year, and the implementation is intended to be starting in year 2 and onward. There are a lot of places where we see alignment with the youth agenda. One in particular, we have one that's very specific and one that's pretty broad. So I'll drop to the specific one first. We built in integrate substance use disorder and mental health standardized screening tools and early intervention protocol into schools. And this was really based on the work that you all have already done with schools in Oregon. And so we are exploring expanding that model of Teen Intervene to several other school districts who have indicated to us that they are interested in implementing it. On a much broader level, we have some targets that are somewhat of a placeholder. The application was very fast, and we did not actually we did public comment, but we did not have really all of the time to meet with all the partners and really discern what is going to be the most strategic investments in rural and remote Oregon to move forward the needle for behavioral health. And so this is a bit of a placeholder. It just says identify strategic investments for improving access. We called out 2 populations in particular, the dual eligible population and children and youth with complex needs. Within that target area, we are exploring projects that do align with the ADPC call to expand support for youth third spaces, so drop-ins and such. Okay, this is a lot, but the, there is our whole application is available on our website, and so you can review all of the different targets and outcomes. But I wanted to bring special attention to outcome 2 because this is where mental health and substance use disorder treatment are explicitly called out. Like I said, there's a lot of opportunity to um, build substance use disorder work and mental health work into some of our other objectives. For example, we have work around mobile care strategies, and that mobile care could be a dental clinic or it could be mobile crisis response. So there's outside of outcome 2, there's a lot of opportunity, but this is where this is the specific place where this is called out. So you can see just across the different years where the different targets land. And then I want to call attention to the bottom 2 rows. These are new. We did not build them into our application initially, but added them after getting feedback about the lack of mental health specific strategies. And so these targets around mental health prevention and addressing unmet mental health needs will be reflected in the grant in the RFGP that will be published. So proposers will be able to respond to those targets along with the others that are reflected on the screen. And then as I said, there's a lot of different places where this intersection can happen, but wanted to just share a bit more around the workforce targets, because I think there's a lot of work that we are doing and that we could use partners in terms of matching these targets to partners and programs that are going to really lift up the behavioral health workforce in particular. In particular, number 4 around increased hiring and training and use of non-physician, non-hospital, and allied health professionals. This is where peers or CADCs and a whole host of behavioral health workforce types of training could happen. Just pausing to see some of what's in the chat. Should it be mental health promotion as opposed to prevention? This was the language that was presented by our behavioral health division, but I can bring that comment back to them, Debbie. Wes, thank you for helping translate what I just shared.
And Lizzie, I kind of put when I looked through, I chair our primary prevention subcommittee. And as I was looking through the slides beforehand, it seemed like a lot of it was kind of, interventions, more clinical as opposed to what we're really concentrating on is delay or trying to prevent things from even starting. Is there a place in there for that type of work? I was struggling kind of seeing it called out.
Yeah, I think you're right that it's not called out as primary prevention. I do think there are a few different places where that kind of work can happen. So we have an area where we're increasing access to services in school settings. And I know schools are a place where a lot of that primary prevention work can happen. So that's what I was talking about around, like, it wasn't specifically behavioral health, but thinking about that as an opportunity to overlay some of the work that your committee might be lifting up would be a great connection to make. Trying to think off the top of my head, there's also some work just around supporting traditional health workers to essentially bring care to people's homes. And I don't know if you would consider that primary prevention, but having more peers and community health workers and doulas engaging well, we called out in particular seniors, but really a lot of populations benefit, might be another place of alignment. And we're really open. If you have particular ideas that you can lift up for us, we have what we wrote into the grant. And then as Yudi shared, um, the place that is undergirding all of this work is the regional planning. We know that folks who are on the ground, those are the folks that are best suited to figure out what they need in their communities. Um, we did the best that we could with a very short timeline for an application, but we want to continue to engage and get feedback about what is really going to be a strategic and sustainable investment.
Okay, thank you. And I think that's maybe something, I see Wes has his hand, but maybe Wes too, as our committee's liaison, maybe helping us connect those dots a little bit. But go ahead, Wes.
Yeah, I wanted to, there's a couple things that are kind of baked in here, and I just want to thank Lizzie and Yudi. They've been so open and so helpful in connecting the dots between our plan and the work they're doing to get a whole lot of money out the door in a very short period of time. I think the conversation, I've steered the conversations away from primary prevention a bit, given the HB 3321 assessment and us not knowing necessarily what is out there. In doing so, I think that for year one, coming back to Lizzie and Yudi and their team about what we discover with the HB 3321 assessment, based on recommendations from the Primary Prevention Committee, where there might be some ideas or supports that might put us further into alignment with the primary prevention plan. In the meantime, I think one of the things that excites me so much about the school pilot program is every single one of those school pilots has asked, who are my prevention people in my community and how do I get connected to them? And so the school pilots, while being really focused on early intervention, they want to have a better partnership with the folks who are doing primary prevention, particularly ADPEP and CPS folks who are doing that work in their schools, so that they can be more in alignment in that way. So that's kind of the partial answer to your question is like, I think there's a lot of opportunity, Debbie. And I really appreciate Lizzie and Yudi being so open to our advice on any of these things, on any of these topics.
Okay, thank you for that clarification. Before we get to Fernando and Mitch, I want to, Erica had, if you find a school district who is not interested in participating in this target, I suggest you consider shifting the investment that might have gone to them to targeted education aimed at increasing their motivation to get interested in the interest of all our youth and families. Thank you, Erica. Fernando, please.
Yeah, thank you. It looks like from this slide you might get to this answering this question in the next section, but I was wondering, will these be direct allocations to the local health divisions to then dole out the money, or will these be direct allocations to the providers? And then a second question will be, how will we ensure that there is kind of fidelity towards what is being proposed? Because one of the issues we continually have in Oregon is that different public health divisions in around the state and around the counties kind of tend to go their own way sometimes. So I was just wondering around kind of more of the structure of how the money's going out and what will be the accountability mechanism to what's being proposed for the grant dollars.
I thank you for those questions, Fernando. I do think we're going to have some slides that can talk about the different mechanisms. The short answer is kind of all of the above. We're using a lot of different pathways to get money out the door. And in terms of support and reporting and accountability, our data and evaluation team are doing their best currently right now to think about what we need to do for administrative success so that we can maintain this funding over 5 years. We are really in the case of direct awards, so for example, we're exploring this direct award for the school districts in partnership with WES. We're really going to be relying on our subject matter experts and partners and connectors to those projects to help us with that. The RHTP team is not, we're not the experts in most of the work that is happening. And so we'll really need that strong partnership and leveraging to understand how things are going. If that helps to answer your question a bit. But I think we'll get into the distribution over the next few slides. Do folks have any questions about the alignment with ADPC at all before we talk about how we're going to do? Yes, Mitch.
Yeah, I didn't have a question. I just wanted to kind of, would you be willing to go back to
Yeah.
like the year 1, 2, 3? Yeah, perfect.
This one?
Yeah, that would be awesome. I just wanted to kind of ground some folks who have been around for a while too. The thing that excited me is the EMSOD reversal, MAT, and ambulatory detox align really, really well, both with the plan and the 4002 recommendations that the treatment committee had put forth. The thing that I know some people may feel a little disappointed about is the timing on some of these, but the thing that I think is really awesome about this is that it is strategic and is going to be done through kind of like what is feasible. I know one of the things that we saw happen previously with some EMS BUPN initiation was that because of the need for a hospital system or other health professionals being involved is so great with this that you can't necessarily just go into a provider community or into a community where there aren't folks for BUP to be available after the EMS leaves you. And so this enables that process to happen. And I think for the other two parts of this, we've been starting to dig into claims, and I think this provides us with an ability of providing funds and services to parts of Oregon that maybe not have had them as easily, for example, with remote MAT and ambulatory detox. So I really appreciated you reaching out and kind of having that back and forth about how and when and why. And it's just one of those, like, even though now would be awesome, doing that carefully and strategically is the better approach. So I appreciated it.
Absolutely. Thanks, Mitch. And these are our targets. So this is what we will be held accountable to complete by the end of year 1, year 2, year 3. It's totally possible that if there is a faster, more accelerated timeline that makes sense for the project, that we can do that. That it's the drop dead for us. Okay, I know we're getting close to time allotted, so I want to make sure we can talk about how funding will get out. Yudi, can I pass this back to you?
Yes. Okay. So we propose to structure the program in a 2-phase, I guess, model. Phase 1 being what we're calling activation, stabilization, and planning. As we know, that a lot of time, consideration, and just space is needed to be really thoughtful with how we get this money out. And while there may be some nascent ideas in certain pockets, certain organizations or project concepts may not have the capacity to turn around so quickly and launch immediately. And that's why we also carved out this space for phase 2, where we assess pilots, where we assess the projects that we're able to get off the ground and see where we can take those learnings and apply elsewhere. But going back to phase 1, we have 3 major distribution pathways that we are getting the money out the door. So the Catalyst Awards is the more official procurement. It will be a request for grant proposal that the team has been actively designing and aiming to publish in April. And this will be the bulk of the money for budget period 1 and 2. For this year, it will be 80 million, and also for next year, it will be 80 million as well. So potentially upwards of 160. And the Catalyst Awards will solicit projects from all types of healthcare providers, including community-based organizations, and they can touch on any of the 4 initiatives aside from the tribal initiative. And then with immediate impact awards, these are going to be direct awards to pre-identified projects or ones that are currently being explored, right, with sister agencies and existing community partners. And then regional planning and innovation is, again, that undergirding force where we'll be providing technical assistance and physical spaces and convenings led by the Office of Rural Health to socialize new ideas, socialize new project plans and models of care, and really plan for phase 2. So sustained awards, that's just a larger description for how we might continue to fund immediate impact awards that have demonstrated success, and also catalyst awards that fall under that same criteria. And transformation awards, this would be, again, the broader, the primary way we're getting money out the door for years 3, 4, and 5. Also placing more weight on those who've participated in regional planning and innovation and apply collectively. Okay. Oh, I guess this is the verbal description of the visual of phase 1 and phase 2. I can pause on either of these phases and see if folks have any questions.
Any additional questions? Or should we just keep moving forward? I think it's going great. Let's continue.
Okay. And so, okay. I realized we actually, Lizzie, we didn't have one of those slides about the budget period and the spending period. So this might be a useful way to at least try to capture that. This is phase 1 and phase 2 mapped and overlaid with the calendar years. And so we're expecting phase 1 really to wind down mid 2027, at which point we'll transition to phase 2, where there's the sustainment of projects that have already been funded in phase 1, have shown to be effective and support sustained transformation. And then we'll run another round of procurement for longer term projects. This is the funding broken down by initiative. From bottom up, the tribal set aside is 11%. So that's how much in numbers of our 197.3 million in award. I would just emphasize that budget years 2 through 5, that's assuming that Oregon gets the same amount of funding each year. And that is not guaranteed. So CMS will be reviewing the state's compliance with this program every September and redetermining our funding. And so in that redetermination, Oregon may or may not get more money or less, depending on how we score on our progress in meeting metrics, outcomes, and targets. And it is a scoring that compares Oregon's progress not only with its stated project plan, but also in comparison with all other 49 states. So that is the competitive nature to this award. And this is a breakdown of how much money is allocated across the funding pathways. So as you can see here, 40% will go towards the Catalyst Awards, 20% will be towards immediate impact, and then 20% to regional sustainability. And actually that tribal set aside should be updated to 11%.
Before we move on, Yudi, I see a question in the chat. How are these numbers arrived at? What data sources were used to determine this breakdown, and who will review and score the grants?
Yeah, so the numbers or the ratios for the initiatives were largely informed by the public comments and surveys that we ran back in the fall, the summer, as well as after we received our award notice, or after we submitted our application. So there were 3 rounds of public engagement. And each time we had asked about projects under these respective initiatives, and through our data analysis, extrapolated how much demand fell under each of those initiatives. And we were really pleased to see that it mapped, roughly speaking, in ratios to how much money we were allocating across the initiative. So as expected, there was a lot of interest around healthy communities because of its umbrella over population health, chronic disease management, and so on and so forth. There was less, I guess, with tech and data, it seems like a really low number, and that was intentional because with a lot of tech and data projects, there's a lot of planning that needs to first happen before the money is spent. And so having heard from our SMEs, internal SMEs, and external partners, we felt that, for instance, budget year 1, we wanted to de-emphasize the actual money allocated to it so that these planning conversations can happen and then ramp it up. So that's just an example of our thinking behind the distribution of money here.
And to who will review and score the grants?
Yeah, so it will be OHA internal folks that will serve on this panel. I think the details of which are still getting fleshed out, but my understanding is we will have panels with subject matter experts assigned to each initiative so that they are reviewing applications by initiative rather than like everything. And then after that scoring happens, there will be another panel to look at geographic distribution, to look at CMS compliance. So it is a very layered approach to the way we're competitively scoring these proposals. Any questions? Okay. Yeah, and this is just a snapshot of 2026. I would say it's been really fast and furious in the ways we have to design and also get ready for implementation. And in early spring, again, aiming for April, we will be announcing the Catalyst Awards RFGP. Alongside this open procurement period, we will be providing office hours to help interested participants or interested proposers refine their proposal and provide that technical assistance where needed. We expect to close the RFGP late spring. I think we're keeping it open for under 45 days. We're trying to make sure that there's as much time as proposers need to compile their application. And also we have this pressure from the federal side to get the money obligated. So by summertime, we hope to announce the Catalyst awardees. And soon after, you can see there with the red marker, we have an annual report due to CMS on August 30th. So it is a really truncated first year for this program. These are the phase 1 considerations. I would say they focus on these 3 broader objectives. 1, to support ready to launch projects so that they can get off the ground and honestly start invoicing the program so that we can spend down funding, stabilize critical services, and help us meet those year 1 targets. And then lastly, activate on those regional convenings so that planning and innovation can happen. And Debbie had a question about who can apply. We are finalizing the eligibility criteria for the Catalyst Awards. I would say, broadly speaking, we've kept them quite expansive because we really want to evaluate the projects and the nature of the projects and their alignment with the initiatives. And we also understand sometimes it's the community-based organizations or the non-traditional healthcare providers that are helping to really round out the healthcare system. So we didn't want to just outright exclude them.
Shira?
Hey, thanks. Can you go back a slide? Just the second goal that says stabilize critical services. I'm confused about that because I was under the impression that this money could not be used to fill cuts and gaps and holes that are created by the Medicaid cuts that HR 1 will create. So I just wonder if you can expand upon what you mean by stabilize critical services.
Yeah, I think you are pointing to an inherent paradox of this program that we will forever, or at least for the next 5 years, have to juggle, which is we can't use the money to replace cut services and the costs that those services take. But we can be creative in trying to expand on services or create new ones that are comparable to the ones that are lost. And I would say just in this space here and thinking about what does it mean to design a program that doesn't duplicate or supplant any other state or federal funds will be a creative challenge. And this goal here, stabilize critical services, is still a North Star. And I think the conversations that are happening here with partners hopefully will clarify what those strategies are. But just to give you an example of what we mean by stabilized services, we know that maternity care and emergency medical services, those are huge issues in probably most of the rural communities in Oregon. And we have designed what we're calling a capacity payment to hospitals, so rural hospitals, where the money would have to go towards keeping their maternity services open, and also they would have to meet certain conditions from a menu of drop down in order to receive the funding. So we're not directly attributing this money to what's already being paid for by Medicaid or what should be paid for by Medicaid, but we're just adding an additional, I guess, like layer of support to ensure that the service itself can stay alive and be delivered.
Thanks.
Any other questions? Yeah, Senator Lisa Reynolds.
Hi, at the risk of sounding a little cynical, isn't this these are like little drops in the bucket compared to how much we're expecting in Medicaid cuts? And you may have said that already, but wasn't sure if I heard that. It's a pretty cynical and harrowing time, but it's great to see this money. It's great to see where it's going, and it won't come anywhere near what we're gonna have to be seeing in budget cuts from Medicaid.
Yeah. I think that is the reality, and that is kind of the truth when we zoom out. It was an earlier slide where the estimates of funding cuts are what, 15 billion, and this may sum up to be 1 billion over 5 years. So that ratio is really stark, right? And also we recognize that this silver lining or band-aid over a bullet hole, whatever analogy you want to apply in the setting, we want to also be good stewards of that funding, right? And make sure that where we can to maximize our impact.
Julia.
Hey, you may have already said this, but I want to be clear before we move forward. Okay, so this is for rural health only. So what are the populations that are being targeted?
Yeah, I would say the ethos, it's rural health. And if we can go back a couple slides, the definition we're using of rural is the one that Oregon's Office of Rural Health has. And that's, I believe, a area with a population center of 40,000. Oh, areas greater than 10 miles away from a population center of 40,000 or more. And so in the light green and the dark green, those are all, by this definition, rural areas of Oregon, which is quite the large swath. And then in the darker green, that's considered remote or frontier, and that's counties with 6 or fewer people per square mile.
But to the population piece, we did not call out any specific, we called out obviously rural residents, and then we identified some populations by age. So there's a focus on maternity, there's a focus on seniors, and then we are elevating the needs of rural residents with complex conditions, whether that be behavioral health or chronic disease management. In our application to the federal government, there is no specific identification of communities demographically, and that was done intentionally in our application. And that doesn't mean that projects that are supporting specific communities, especially communities that experience health inequities, should not be prioritized in the way that we are awarding these funds. But it's part of the balance of this program.
That's where my question, what are the demographics of the folks? Because we know that in Native American communities, there are severe health disparities. And are we really paying attention to the demographics of those folks, the Latino folks? And obviously, Multnomah County has the most impact. I mean, not impact, the most demographics of African Americans are in Multnomah County, but there are some in Eugene and Salem, but doesn't look like those are the areas that are being targeted. They are, or to better words, say omitted from this. But I just, concerns about, the folks that have the higher risk of health disparities, and that they are being addressed in this. Because what it seems to me is that these populations, including the African American populations, are always the lowest on the totem pole when it comes to funding for their health disparities.
I can try to at least one honor, yes, those health disparities across racial lines exist and oftentimes concentrate in urban areas. And something else that we've been trying to hold in the same hand is the political pressures coming from the federal government and, you know, frameworks and efforts around health equity are under attack. And so when we're thinking about compliance, program integrity, what we report to the federal government, that is a very fine line we have to walk here, especially with accepting these federal dollars. And so in our application, by design, we did not use those terms, right? And health equity describing that, when we also know that as a state, as an agency, that is a bedrock of how we design our programs and policies. So for this program, the disparity that is really the primary focus here is the urban and rural divide, as far as access and outcomes. And where we're able to buoy learnings and services in urban areas because of the way they interplay, I think that would be a beneficial byproduct, but urban centers are not the focus of this program. And that is also a statutory recommendation or requirement, excuse me.
Well, I understand
Mhm.
that, but it doesn't mean that I don't have concerns about all people, right? And we already know, I'm just going to say that this government entity does not look well, or like they don't seem to prioritize people other than white folks. So
Yeah.
Okay.
people
Julia.
Appreciate everybody's comments, and I want to
Yeah.
stay true to our time. And kind of repeat what Wes said earlier, that we really appreciate you seeing this funding opportunity and align it with the goals that the ADPC has. I think, again, I'm sure those of you that have been around a little bit longer, this is my first time of really seeing a coordinated effort like this. And so I think this speaks volumes to what we're all trying to do here together. So it's very appreciated. I think we will want to continue to stay engaged. But thank you for including us with this. This has been a really informative presentation.
Thanks, Debbie. I want to just say one more comment to respond to Julia's question, which is that to Yudi's point, with all federal funding right now, it's a balancing act, and there's consideration to the communities that are experiencing harm right now. And there's also considerations to making sure that we are protecting people's data and information as well. And so there's different reasons why we might not want to call out or collect specific data at this time and place. And this isn't specific to RHTP. This is any program that's getting federal funding is contending with the same challenges. But I would also invite that if there are strategies or programs or partners that are doing a really wonderful job of closing that gap in their community or really engaging folks to create solutions for themselves, those are projects that we would love to be able to fund if it's the right match for the project. So whether that's encouraging those partners to apply for the grant funding or elevating those learnings and those entities up to us, want to keep the door open on that, because this is a challenging time, and we really are going to need you all and a lot of other partners to make sure that we are walking in alignment with what Oregon's goals, what we know Oregon's goals are. So thank you.
Thank you, Liz.
Real quick, I think Shira had her hand up. So Shira, I don't know if you have a question. And Devin, I'm so sorry. We asked the members of the public to hold comment until the end when we get to public comment.
Thank you, Annalise.
Yeah, I just wanted to really like appreciate and honor the work of OHA in walking the middle ground between federal expectations right now and rolling out these dollars in a really short amount of time. And also just offer, as a provider in a rural health setting and hearing from my fellow CEOs in rural Oregon as we continue to have conversations about this money, people are nervous about it because it feels soft given the annual redeterms. And I'm sure you know that, but just kind of wanting to say that out loud for the larger group here too, that as we're considering like, what program do you want to roll out and having to prove efficacy in a year in order to get money again, and also not necessarily knowing if that money will be there, has, you know, leaders of organizations a little bit reticent and anxious about applying for the money and really knowing, you know, how to leverage the dollars in a way that feels meaningful but also safe for our system. And it's really challenging to, you know, want to use this kind of money for FTE, right? To bring on people. So anyway, again, I really appreciate all of the work that OHA is doing. And of course, you didn't create the model that exists within these grant opportunities. And those are the realities and the conversations that we're having out here in rural Oregon as we're trying to consider, how do you spend the money? How do you spend this kind of money in a way that will have an impact, but also be safe for the system?
Thank you, Shira. And thank you both, Yude and Lizzie. We really appreciate you being here and presenting. Keeping us on track here for time. Wes, would you like to give us our legislative update, please?
Yeah, I'm happy to, Debbie. West River Senior Policy Analyst for the Alcohol and Drug Policy Commission. I wanted to go through a few things because at the beginning of session, we provided you with a few bills that we were keeping our eyes on. As you're probably aware, several of the substance use bills died. And so I'll just go through a few examples of those. With respect to, I know our prevention committee was watching quite closely some of the regulatory measures with respect to cannabis. So HB 1548, as well as HB 4139. There was another one I'm just not having quite up on my list, but those bills either died in committee or died on the floor, so those are not going forward. There were also some pieces around changes that we've seen to Measure 110 in particular. So I know that was a big topic of interest at our last discussion. That was with respect to moving some of the functions of the OAC to the Criminal Justice Commission. That was SB 1583 that also died. There was citing requirements with respect to syringe service programs that also failed to move and go anywhere after the committee hearings. And then finally, the big regulatory bill that we were watching in prevention around cocktails in a can, or providing low proof distilled spirits cocktails at grocery stores. So that did not go anywhere. On the plus side, the Governor's Behavioral Health Talent Initiative recommendations, that bill moved forward and was signed by the governor. And And then, so that was House Bill 4083. HB 4070, I'm bringing this up. It did several things, but one of the things did was it cleaned up the language and destigmatized a lot of the language around substance use throughout statute. So if you want to take a look at that, that's a good one. It also passed, moved forward. And then the only other one that I thought would be of interest to folks is SB 1547. So this is creating a new credential around bachelor's level associates with respect to behavioral health services. And Senator Reynolds, if you'd like to talk about your bill, we appreciate you being here today.
Yeah, if I have a few minutes, I have a few things I'd love to share with you all. So yeah, we call that the Balmer bill, the 1547? I'm really bad at bill numbers. That last one, the bachelor's
Yes,
level.
1547. I was going to
Okay.
say that, and then I saw you come on. So yeah,
Yeah,
go
yeah.
ahead. Yeah.
So yeah, and that's great. That's based after the amazing undergraduate program at the Balmer Institute, where these young people graduate with 700 hours of practical kind of classroom and clinic experience. And then they will be, so it's a licensing path, it's a licensure kind of scheme for them. And then they'll be able to hopefully bill for their services, but they will always be, they can't diagnose or treat, but they will be overseen by a psychologist. And just kind of I think another pair of highly trained hands in a classroom. My marijuana bill, which was 1548, which would have required, and I talked about it here, I think in January, which would have required that each unit of an edible be 1 serving size of THC, which is 10 milligrams, and then that it be individually wrapped. We had an amazing public hearing on this with like the director of poison control and ER doc, drove down from OHSU and talked about the perils of toddler toxicity. This was a bigger bill when we started around labeling, around maybe some potency limits, and we kind of shaved it down to just the toddler poisoning prevention, thinking that was kind of low-hanging fruit. Actually passed in the Senate in a really fun Senate floor hearing where a lot of people were making up a lot of lies. I will just tell you all, and I've said this publicly, and I know this is a public meeting, it's pretty shocking to have my colleagues, including people I really trust, parrot back the marijuana industry verbiage which were not true, things that were not true. So I spent a lot of time putting out whack-a-mole fires. And then the lobby just got to the House faster than I could get there. And so it died in House committee. I think one of the problems is it got sent to the House Committee on Economic Development, whereas it was in my committee for behavioral health and early childhood. So there's just a lot of savvy things the lobby can do. And so I'm really regrouping, and I want to come back stronger and more powerfully and with more resources in 2027, specifically around preventing, baby poisoning of THC, but more importantly, preventing adolescent and young adult cannabis use disorder through labeling and potency regulation. And I think I'm really trying to find some national money to hire a lobbyist, but any way we can work together on that. The needle bill, I have been raked over the coals on the needle bill, and I've even garnered a primary challenger because I want children to play with needles. I mean, who knew? But here's the thing. I think the way the bill was written, and it was written by Drazen, it was clearly political play on her part. It would have done away with harm reduction in the entire state of Oregon. It was that no mobiles can distribute harm reduction materials within 2,000 feet of a school or a daycare. 2,000 feet is 0.4 miles. So I think except maybe out in those frontier counties, there's very few places certainly urban places where you can get 0.4 miles where there's no, radius, where there's no school or daycare center. And furthermore, we have no idea of tracking. We have no way to track daycare centers. I offered an amendment working with the coalition of local health officers to say, let's say 1,000 feet of just a K-12 school. And instead of a $5,000 private right of action, if you find a needle in that radius, start working on a registry. And the she sponsored the bill. Senator Drazen did not agree to that till she actually agreed to it like 15 minutes before our final committee meeting, and it was too late. We didn't have the paperwork for that. But I will tell you, we have to do something. I mean, there are needles in our community. There's needles all over the city, and I know I didn't ask for time on the agenda, but I really would like, over the next few weeks, people's best thinking on how we get rid of needles on our sidewalks, because it is horrific. And my community is really, really angry. And they feel that I'm the one who blocked it and I don't really care. And I care more about, whatever. But yes, and I would love Moxie's, and I have to do something. I mean, I have to do something because it's the right thing to do, but the community is really upset with me, and I have to do something because I agree with them, and we need to do something. So I know I'm going a little off topic, and I'm happy to carve out time at a different meeting, but I love being in this group. So thank you so much.
Okay, I want to thank you, Senator Reynolds and Moxie. If you want to go ahead, we can keep it real brief and we'll get on to committee updates. I'm trying to do my best, Tony, who's so good on keeping everybody on task.
Yeah, I mean, I know that, well, thank you so much, Senator Reynolds, for your ongoing effort and dedication over the years, as well as like your other day job. That's a lot of work. So I think maybe a good common ground that would be the least kind of political or divisive might be to just talk about how harm reduction agencies could go around and gather safely, if they can do this, gather the needles that are out in public that nobody has on them and just dispose of them, because then everyone might end up appreciating what they do, because they're not just giving out clean needles, they're also getting rid of ones that could cause infection and injury. So I think we could probably get a coalition around that. That's pretty, hopefully bipartisan. Maybe I'm too optimistic. Thank you.
Thank you. And we'll need to get used to our new name of our former harm reduction committee, so we can even start helping people see that we don't have to be afraid of these things. So thank you again. Health and safety interventions. Thank you, Mara. I was looking for the notes. So with that, let's just start with committee updates. And I'm going to go in no particular order, but how about we start with our health and safety interventions subcommittee? And that's going to be Stacy. Are you still here? Would you like to give a brief update on I mean, you kind of already did. Is there anything else you'd like to share with us?
I think Stacy might have had to step away for a moment, so
Okay.
I could just give a brief update on what we're doing over at Health and Safety Interventions. So as Stacy shared, we have now officially, because y'all voted for us, changed our name. So we are now Health and Safety Interventions. Our next, and that has taken the first couple of meetings of the year. So that was a January and February endeavor. Our next project is updating our bylaws. So I'm in process with a smaller ad hoc bylaws group right now, working on those, and we will talk about scope and bylaws and all of these like nitty-gritty things that are going to be happening. In March, we might be changing our day of the week, or not day of the week, but day of the month that we meet. So we're doing all of the background stuff right now. And then we'll do a preview on our naloxone stuff that we are working on, our naloxone strategies. And then April, we are going to dive into naloxone, all things naloxone. So that is exciting. And our group has grown. We got 2 new folks, one from Eastern Oregon and one from Southern Oregon. So great, a lot more representation in our group. We're very excited, and we look forward to collaborating with the other committees as well this year.
Great. Thank you so much, Mara. How about Katie with treatment?
That's me today, actually, as well. Katie can make it today. So my name's Mitch. I staff treatment committee. We kind of, I think, similarly to a lot of the other committees, we're doing a bunch of housekeeping. I think as we came into the year, some minor bylaw amendments. We have one more committee change potentially happening this week, but we've been
Good. There's no more eating right now.
Oh, hey, Tim. One thing we've been doing to try to focus our very large body of work in the treatment committee. For those of you that aren't aware, we have some pretty grand ideas what we hope to do over the next 5 years. One of the hard parts for our kind of part of this is that we have outpatient, intensive outpatient, residential services, inpatient, withdrawal management, medication. We have like a pretty wide thing to do. So what we've been doing is trying to narrow that focus. And I believe this week we should be narrowing that into what we'll be doing for at least the next, probably, yes, rest of this year. So, do you have any
Thank you
questions?
so much. Mitch, do we have someone that's filling in for Tony with the recovery community?
Yep, that's me. We've got lots of subs today. Will is out as well. The recovery committee will meet again next week. They have really jumped right in. So as Mitch said, a lot of the committees are doing assessments, etc. Recovery committee has an opportunity this spring at Peermageddon, which folks might be familiar of, the mega peer conference down in Seaside. A group of recovery community center leaders are going to come together and talk about and review a proposal from the recovery committee to define guidelines for recovery community centers. So it's pretty exciting. They dove right in with that last month. They'll be talking about that again this month. That is going to be the basis of the conversation to start to work with the youth to think about what do we think are the best practices around this concept of recovery spaces. So that's very exciting. So that's what the recovery committee is up to right now, recovery community centers.
Okay, thank you. Erica. Oh, yeah.
Oh, yeah. Let's see. The Oregon Youth Addiction Alliance has been doing some light housekeeping, really focused on updating our charter, recruiting new youth members. I think we're looking for maybe 4. We had originally had a deadline of that application process of March 1st, but the youth agreed they wanted to extend that to, I think it's March 20th. For those youth members, we're really targeting Central Oregon and Eastern Oregon to get kind of broader representation, and then also youth who maybe have experience with recovery schools or other alternative education programs. So really hoping that we can ask our commissioners and public folks here for your help in getting that link out. If maybe we can post it again in the comments section, would really appreciate your help with that. Over the next couple of meetings, we'll be focusing more on carceral settings and youth recovery spaces. Our next meeting is this Wednesday, March 11th from 4 to 5:30. Invite folks to join and help recruit youth. Thank you.
And just like you said, Wes has that application in the chat. Please feel free to share it wide. This is all the groups, all our committees are awesome, but I tell you, I've really enjoyed when this group gets together and the powerful work they've done in testifying, and it's made a big difference. So last but not least, the Primary Prevention Subcommittee, which I can give you an update on. We have voted on a vice chair. Luis Pimentel, who is from Lane County, will be joining us, and I'm very grateful for that. So if you don't know Luis, an outstanding new dad. And so that'll be a great thing that we'll be able to have. And I saw Tim on here. He popped in for a second, I think accidentally, but we are really steeped right in the work right now of starting to work on our strategic plan. And Tim and Third Horizon are assisting us. And one of our first big tasks that we're taking on is kind of twofold. One, the effort that's continuing with legislation from last session, not the one we just finished, but previously with 3321, where we're taking a deep dive into funding. We really appreciate the letter that Governor Kotek put out, informing other state agencies to share budgets. So this can be, we can meet the deadline that the legislature has asked for providing this report. So Tim and his team are working on that. And then we are also working on, we don't like this name, but this is where we're kind of at right now, as what would a primary prevention center of excellence, and again, don't get sold on the name. We might have where the health and safety people help us come up with a new name, since they did such a good job with theirs. But this could be a one-stop shop to where we can really bring the importance of primary prevention, the definitions, work that's happening, and very much like the presentation we just had on the role of health, that it'll be ready to be implemented in all those spaces. So that's the work that we're doing. We have, by my math, 17 minutes for public comment, or if there's some other questions that our commissioners may have. I do want to put this out before we open up that our April meeting, we will be, let's see, it says we'll have our first comprehensive plan quarterly update. And also be taking recommendations and a vote for chair and vice chair. So if you have some thoughts on that, please get back with Wes or Annalise on that. And
if I can just add to that real quick, Moxie,
yes,
before we
please.
go into Moxie, I saw Moxie right there next to you, Debbie. Before we go into public comment, if anyone is thinking about chair or vice chair, I've heard from some folks, if you could reach out to me just so we can have a conversation before the next meeting about what all it entails, that would be great. But yes, the intention is next month for you all to make a recommendation. That won't be the end point, because we'll have to make the recommendation to the governor's office, and then we'll have that person in place by the summer when Tony's term is up.
Thank you, Annalise. And as I think we're getting warmed up, some public comment, please, I think, Devin, if you're still here, I think I saw a hand back, and anyone else, or if you want to put something in the chat. I do want to, just because this has been, I think, such an outstanding thing, want to recognize Stephanie Condon. The things that we're getting online, the LinkedIn, really keeping our state informed. I really look forward to reading those. So kudos for that. Devin, please.
Hey there, Devin. I actually own and operate a sober living company here in Portland, and I've been doing a little bit of networking, and I took a few notes. I don't know how much time I have to chat. Also, I don't know if because I'm not on any of the committees or this like list, if I can throw my hat in the ring, Annalise Dolph, for one of the positions that's coming up, but I am very interested. I was told by Tony that if I start coming to these meetings and raising my hand and saying hello, that I might be able to, that's the best place to start. One of the questions I had for OHA earlier is because it's moving so fast. I don't know if there was a list of organizations that you already work with. It sounds like there's not like an exact list of the communities, but I was a little bit confused because it is moving so quickly. If there was like a list of professionals that have the data, and any list would be helpful. I saw the map, but I was a little bit curious on how we'd be able to move so fast if there wasn't a list of like specific rural communities that we would be working with directly, or organizations that are already kind of in those communities. And I have some ideas on some of those professionals just from the work that I do. I know Iron Tribe does a lot of work in the rural areas. And yeah, asking about the list, and then asking about how I get a position and getting on board. And I plan on trying to hit all of the committee meetings. And I got the list, and I talked with, I have to say, Ashley Olson on helping me steer through the app. So I appreciate that. And thanks for having me.
Thank you, Devin. We appreciate you joining us and showing us your face and being willing to say, hey, sign me
Yeah.
up, coach, I'm ready to go in. So I'm sure I can make the assumption that we can do some follow-up with Devin, Annalise, or Wes. I'm seeing heads nod.
Yep, we'll follow up, and just always emphasizing all of our meetings are open to the public. So you don't have to be a member of a committee. And Devin, hopefully you saw in the chat, OHA had left some links in there about the program. And so hopefully that will help with that. And I saw Moxie had her hand up too, Debbie.
Okay. Looking for that. Moxie, are you still here with us? I don't see your hand. Any other members of the public? This is your chance. We'll give Senator Reynolds back the floor if she wants more time. Go ahead, Senator.
Yeah, I'm happy to. I mean, again, I would just, I'm delving into, it's very interesting. The community, I can see it from my window here, that it's called Stadium Hood, near the soccer stadium in my community and in my Senate district. And they actually offered a bill in the 2025 session, which would have been 1,000 feet from a school, with just the registry, which is actually the amendment I proposed this year. And they're really caught up in like, it cannot be near a school. And I'm like, well, really, the answer isn't like where the needles are given out. It's that the needles are on the ground, which of course is tied to where they're given out. So I'd like that Moxie said, you know, there needs to be more responsibility to the folks who are distributing the needles. And actually the bad player in my, I'm going to call them a bad player, sorry, PPOP, which I can't remember what that stands for. So it's an independent organization. They don't do any exchange. They just hand out needles. So I think I'm looking at, you know, where do we find this where of course, I do not want to get rid of harm reduction, but I also think the trade-off that there are needles, you know, strewn around a school is not an okay trade-off. So anyway, just if you all, I'm kind of repeating myself. If you all have thoughts, research, evidence, you know, we're looking at what other states are doing, what other cities are doing, because, and it's not just my community, you know, my you know, colleagues in Southeast are saying the same thing. And I know we all, you know, but I appreciate getting a few more minutes just to flesh out what it is that I'm really head down working on right now.
Thank you. I know I had a colleague in Lincoln County who mentioned what they had to deal with after a storm surge on the beach. So I think there are things that we can, you know, as we're beginning to talk about this, be better prepared. So thank you for your efforts in keeping that. Hey, Nikki, my friend.
Hi there, how you doing? I just have a question and I'm not sure if it applies here. So is anybody from the Rural Health Transformation Project who presented, are they still on or have they left? because I don't want to ask a question or drop a comment in because it's really for that project. Would it be better if I just posed my question directly to their website? I'm seeing Annalise nod her head. Okay.
Yeah, and we can probably get you those emails to Nikki to make sure that you're able to address your question directly to them.
Fantastic. Thank you.
Okay. I'm lucky enough to get to work with Nikki. Some of you don't know her, but she's doing some outstanding work here in the Gorge with our first kind of treatment center. So Nick, thanks for popping in and visiting us. Okay, anybody else?
Well, I will send a follow-up to folks just asking maybe about this summer to get a pulse from folks about which month would be better to cancel and see if we can get any takers on upcoming in-person meetings.
Thank you all so much for being here. Continue to do the great work and oh, Julia, did you have something?
Hey, Annalise, so just to let you know, we bought out our general partner, so Miracles Club now owns this building. So it might be a good thing to come and visit us and see some of the changes we're getting ready to make.
That would be great. All right, Julia, I'm going to follow up with you on that.
We have our first invite to come through. So way to be on top of that, Julia. All right. Thank you everyone so much. Have a wonderful St. Patrick's Day. And we will all see you next April.